we are together here today to have the chance to present our projects to each other, and with this open, of course, hopefully, a lot more synergies during the upcoming years. We already had some bilateral meetings, we started to know each other, but from here, there's plenty of possibilities of collaboration, and we really need all the help we can get, learning from each other, because this will, of course, also means that we can perhaps tackle some challenges and take advantage of each other's research and implementation, hopefully, to be more successful in our projects. So the idea is first to have, let's say, two presentations, one from, as I was mentioning before, the HADEA project advisor, Marina Cusatana. Then we will pass the floor to Isabel Bandurek from GACD, who will also make some remarks on the Global Alliance. Then the five projects will present. We will have 7 minutes for these presentations and then have hopefully some time for discussion, especially to understand a bit more between each other, put any questions that may raise during the presentations, and most of all, align on what we can do next, which is, of course, the more exciting part of this. So without any other remarks at this moment, I will then pass the floor to Marina, if you agree to share your screen, and we can start with the presentation. Thank you so much for being here.
Good morning to all of you. My pleasure to be with you and to inaugurate this cluster of the GACD projects that were funded from the work program of Horizon Europe Health Clusters of 2024. I represent here, I'm Marina Cusatana, project advisor at the European Health and Digital Executive Agency. I represent a group of people that you can see in this slide. First of all, Greg Ovsianik, who is the policy officer working at European Commission, the DG RTD, the Directorate of Research and Innovation. Greg couldn't be with us, but he worked with me, and that's why we help a bit and assist to involve Isabel from the Global Alliance for Chronic Diseases to give you the big picture of the priorities of GACD and perhaps the big family of projects that are funded globally in the context of non-communicable diseases. I represent also the team of project advisors that you know very well, that are responsible for your projects, Andres Moya San Martin, Cristina Padeanu, and Athanasios Rogdakis. I was very happy to be topic leader in the evaluation of this call of Disease 13 of Horizon Europe. And I worked with this team very well to find the best projects. So my presentation is to present, first of all, the authority, who we are and what we are doing. Secondly, some basic key principles that you have to take with you on project management. And last but not least, what you want to hear, what could be the network, your networking activities could reach, and how you can have raise the impact of your projects. So I'm starting with a presentation of our agency. Our agency, as I said, is the European Health and Digital Executive Agency. It was set up in 2003. 2002, April 2002. The executive agencies are called executive because they execute funding programs of the European Commission. So our agency has been entrusted to execute programs of the European Union in the area of health, digital, food, industry, and space. But how it works that? Because it's not always that clear. So we have the European Commission on the one hand, which is various directorate generals, like the Department of Santé, the DG Research and Innovation, the DG Connect for the digital priorities of the European Commission, DG HERA for Health Emergency Response Authority. So these departments, they define the policy priorities. And then these policy priorities are drafted in work programs, and then the Commission adopts these work programs in decisions. On the other hand, the executive agencies, they take these work programs and they implement. How? They implement the calls for proposals. They evaluate the proposals and they found the excellent proposal to be granted. They work with the excellent proposals to prepare the grant agreements. They monitor the projects. And last but not least, very important, give feedback to policy, which means the success stories of the funded projects and the knowledge that they generate is given back to the European Commission for defining new policy priorities and most importantly, for having the impact to the society, because we don't forget these are public money that we are using, and our main target is, our main aim is to provide, to generate impact for the well-being and the health of EU citizens. Our parent DGs, you see it in these slides, are the DG Santé, the DG RTD, the DG Connect, and the DG HERA. In this multi-financial program, which started in 2021 and lasts until 2027, my authority, HADEA, will manage around 20 billion. You see here in the chart the programs that we manage. I will focus mostly that half of our budget is devoted to health. This was the response of the European Commission in the COVID crisis. And we have, as you can see, two different budgets, the EU for Health program with 3.8 billion, which is mostly for capacity building in the member states. And then we have around 6 billion from the other side of Horizon Europe, which is mostly research and innovation action in the area of health. Now, what is our portfolio? You can see in the slide that we are managing already 473 projects that are coming from the calls of 2021-2024. 64 projects are in the grant agreement phase. So we prepare the grant agreement and they are coming from the calls of the work program 2025. 28 projects additional will come from the calls of two states of 2025 work program. We have soon evaluation for the work program of 2026, and we estimate to come to fund additional 86 projects. And we have also the legacy of Horizon 2020 program, which still are ongoing 157 projects. The average grant size is approximately 8 million, mostly research and innovation action, but we have grants with higher budget like 100 million, like the partnership on chemical risk assessment or on brain health. All that projects are for Horizon Europe Health Cluster. Okay, not for all the projects or all the programs we have in my agency. And all these projects are managed by my unit, which is HADEA A3 unit. It's called the Health Research Unit. And we have 42 project officer advisors, 5 assistants and 1 communication correspondent, 2 call coordinators and 4 managers. We are working close with financial officers who are responsible for the financial of your projects. In particular, the sector C14 of HADEA, with 13 financial officer advisors, 1 legal manager, and 1 head of sector. So, as you are in the beginning, I will provide you just 2 slides about success on how you can increase the success of your project when you manage it very well. So, when we talk about projects like yours, big projects, collaborative, multidisciplinary projects, the success depends on some factors. The first factor is on strong leadership by the coordinator and active management, good project management. No matter how good research a project, a university, an organization is preparing with a bad project management, the success of the project is not that visible. But it's not enough only the work of the coordinator. Projects like yours require dedication from every one beneficiary, a commitment from every one beneficiary. And last but not least, it's important to have a good working relation with us, with the funding authority. We are here to help you to manage your project and implement your project and achieve what you promised and the impact you promised. And we are keen to have a transparent and good relation and good communication with you. So some key elements that you need to have in your mind about your project management. First of all is the grant agreement. The grant agreement is the Bible, is that all the coordinators, but also your beneficiaries should read very well and know very well. It's your contract which describes your obligations and what you promised. Everyone that participates in the consortium should be aware about those obligations. And there are many instruments in our website that can help you to understand those obligations. Like the AGA, we used to say AGA, the annotated grant agreement, you see the link here, or the online manual for grant management on participant portal. We are suggesting to keep your project on track time-wise. Extensions are very rare granted, exceptional granted, and only if the project faces something that it is emergency, like it happened with the lockdowns in the period of COVID. So you have the continuous reporting with your deliverables and the milestones, and the periodic reporting, which usually is every 18 months, and it is linked with the payments as well. So keeping track your obligation and fulfill on time administrative and financial obligations. Be ready for regular project monitoring review. We have several levels to review the progress of your project. It can be a scientific review. It can be a review linked to the reporting period. It can be a review on ethics, and in particular, some of your projects, of your family projects, they have sensitivities of ethics. It can be, so we can have an ethics review together with the European Commission. And last, certainly at your final reporting period, we will have also innovation radar review together with the project review to capture the innovation that the projects brings. Do not forget the horizontal aspects, like the ethics. I said also before that, in particular in your projects where we have exchange of health data with third countries, we have ethics approvals. Be sure that you implement everything before you start any activities, and you have the ethical package fully established with the authorities in the third countries. Do not forget your obligation on open science, and of course your dissemination and exploitation activities that will increase the impact of your projects. But last but not least, we have the communication with us via the participant portal for business continuity, but also regular communication when emerging risks appears in the project. And certainly for the time, usually the projects in their life cycle, they have several emerging risks. Do not hesitate transparently to discuss with us and to find solutions. And in some cases, you can have amendments of the grant agreements. For example, when a beneficiary is terminated, or when a coordinator's bank account changes, or even the coordinator is changing during the duration of the project. So again, an amendment should be timely launched, because it will block your reporting periods and your payments if it is not timely launched. So I don't want to say a lot of the here, because our role is to inaugurate your networking activities. So allow me to remind you a bit the concept of the topic that you, under of which you have been awarded. So we talk about the implementation research in the context of Global Alliance for Chronic Diseases, GSCD. Horizon Europe Health Cluster has always a project, a topic call in the work programs every year, which is of which the focus is changing. So in the work program of 2024, the focus was on the management of comorbidities of multiple long-term conditions in the context of non-communicable diseases, but always the target group is the same, to support low middle-income countries to manage those conditions, or to support disadvantaged populations that they have health disparities. For example, underserved populations, or a population in high-income countries that have health disparities and they don't reach the health systems and the healthcare easily. So the work program of 2024 called the proposal to have the successful proposal to have to come up with a validated implementation research frameworks that are ready to be implemented, to come up with a strategy that can measure implementation research outcomes and real-world effectiveness, and to focus on health equity and the principles of universal health challenge. In terms of implementation, the consortium should have an appropriate research team with skills in implementation research and suitable multidisciplinary approach. But also it required to have equitable partnerships and shared leadership with partners that are coming from low middle income countries or teams that represent disadvantaged population. Then impact is related with stakeholder engagement, but also with sustainability of the intervention proposed, and also capacity building, focusing mostly on building capacity on early career researchers, on implementation research, and last but not least, the reason we are today, networking activities between sister projects and the GACD. So you are 5 projects. We had 75 proposals, 5 funded, and the total allocated budget is approximately 20.3 million. Each one project has almost 4 million, and the family is this one. As you can see, the duration is different. The number of participants in each consortium is also different. What is the added here value is that almost 53 organizations working in implementation research in the context of non-communicable diseases can create a big network. So what we see for us around your networking activities, it's an opportunity, first of all, to share information about the projects, to foster the dialogue between the various coordinators and between us and the European Commission services, and to increase the chances of success and raise the expected impact through, for example, exchange best practices, expertise and experience, or consider ways to optimize your dissemination and exploitation plans and training, and seek synergies with a big family of the GACD projects that I'm sure Isabel in her intervention will capture. What we can offer, as I said before, one of our action is dissemination and feedback to policy. We can encourage and support your dissemination and communication activities. We can, you know that there is the Horizon Results platform where you can publish your outcomes. There is the Horizon Result Booster that it is a consultancy service that the European Commission offers to boost your exploitation activities. We can facilitate your contacts with policy DGs and foster clustering of your project. And last but not least, to encourage engagement with stakeholders, for example, by sharing good practices. So apologies for that long presentation. I would like to thank you for your attention, and I'm looking forward to hear Isabel and the coordinators and the discussion at the end of the project, of the discussion today. Thank you.
Thank you so much, Marina. It was very interesting and I'm sure relevant to all of us. So perhaps I pass directly to Isabel to catch up on the continuation.
Lovely, thank you so much. And again, thank you for inviting me to be here. It's great to get to know you all a bit better. I've met some of you before, but it's great to meet more people. And thanks for that introduction, Marina, to how all the EU side works. But I'm going to talk now a little bit more about the GACD, and my job and our role at GACD is to help you do all of those things that Marina was just talking about. So we exist to help you do that, help you do the networking, help you link up, help you find those synergies and action them and do something. So just in case you're not familiar with us, GACD, we're a worldwide alliance of the funders. So you can see across the bottom, there's lots from all over the world: India, South Africa, Australia, and of course the European Commission, under which you are all funded. However, we have funded, since 2012, we've funded 9 programs so far, and that funding has covered over 400 million in that time period, with over 190 projects in more than 90 countries across the world. So there's a huge diversity of location, of populations, of conditions, and you can see that we started with some condition-based funding calls: hypertension, diabetes, lung diseases, and then in the more recent years we've come to be more holistic in that approach, so around life course interventions, healthy cities, and of course the multiple conditions, which is where we are today. Now, typically, I think we think about grant calls, we think about these silos of, well, I'm funded under this and that's my project. But what we try to do at GACD is flip that around and bring everyone together. So from our perspective, we believe that all of our projects are already part of the GACD research network. So regardless of when your project was funded, where it's taking place, or who the specific funders are within GACD, we bring everyone together to talk about their projects, because there is so much synergy and commonality among you all, despite the apparent differences. So what do we do in the research network? Well, we hold research program workshops. These are online and they're every 3 months, and we invite all projects to come together to talk through what's going on for them at the moment, what challenges they've experienced recently, and also how they can help each other and share what they're doing, or perhaps share tools that have worked for them recently. So for example, I brought together some projects who were all working in Nepal across totally different grant calls, but now they've got a consortium together in Nepal, and they come together to share their knowledge, their updates independently across time. We also have our annual scientific meeting, which I will come to. This happens every year. I believe it's part of the agreements you have with your funders that 2 people from each project should come along. And these are in-person meetings. They're 3 to 4 days long. They take place all over the world. So last year we were in Kigali in Rwanda, which was an incredible experience. And before that we were in Singapore, and it's been all over the world in the past. These are great events to connect, to network, to find new friends, to really dig into those collaboration opportunities. Indeed, in Kigali last year, people who had never met before found each other during that event and submitted a grant that then got funded over the last year. So the magic can happen at these events, and I encourage you to look into this. I'll share a whole load of links after I stop talking so you can follow up afterwards. But these are a great opportunity for anyone in the project, but especially those slightly earlier in their career who might benefit from those networking opportunities. We also have our joint activities. So these are things, working groups and special interest groups, and they bring together researchers, implementing partners, coordinators who want to tackle themes that are relevant across projects, whether that's the condition that you're looking at, or the context, the population, perhaps it's even what you're implementing, the intervention itself, or different methodologies that you're looking at. And we do have active special interest groups that you are all invited to participate in. You can just get involved. They are open to everybody in your project. So if any of these take your interest, you can get involved. And often they will produce something together. So it could be a tool set, or it could be a blog or a report, or maybe it's even an event itself. Or it can just be routinely getting together, sharing what's been going on, or sharing any knowledge that you've gained recently. So in case you are interested, our active special interest groups span quite a wide range of interests here, so active mobility, children, adolescents, data standardization, equity, humanitarian work, indigenous populations, nutrition and food systems, my personal favorite, I am a dietitian by training, and planetary health. So if any of those are of interest to you, just get in touch and you can join them straight away. But equally, if you've got something that you would like to pursue, an area that you think would be of interest to multiple projects, let me know. We can support you to create that group and bring people together. We also support capacity strengthening. So you are not on your own. You don't need to do this from scratch every time. We run a school every year. We recently ran our very first Express workshop over 2 days to introduce those who are very new to implementation science to the field. We have an open access eHub, which has got on-demand programs. There's lecture recordings from experts from all over the world. It's all completely available to anyone who wants to look up. We have a masterclass on Scale Up. This time last year, I was in Goa in India with our second cohort completing this program. And we also have public thematic workshops that happen every year. So we've had one on theories, models and frameworks, which is a common theme among implementation scientists, as well as ones on context, on reciprocal innovation. And these are all open access to catch up on whenever you would like. And I would just like to plug something as well while I'm here talking about capacity strengthening. We have a workshop series that is starting in just a couple of weeks, and it is open to anybody working on a GACD project. So that's everyone here, plus all of your colleagues who are also working on your projects. And it's a series of 6 workshops that are designed to help you build your skills and your confidence, in science communication. So starting off with what your project's key message is, public speaking, how to put that into something visual, how to turn it into a film, facilitating those conversations and focus groups, and then eventually publishing, so writing those publications, but also things like policy briefs, case studies, and social media. So again, I'll put the link in the chat for you to register. I would really encourage you to get involved in these. We have wonderful expert speakers, and these are specifically for GACD project researchers and colleagues. So what I would recommend to everybody here is, if you haven't already, sign up to our research network, join the community, get involved with us. We are a friendly, informal bunch, and our aim is to help everyone to come together. So do sign up. Come to our communication workshop series. That is starting very soon, and right at the beginning of your project, it's a great opportunity to really cement those communication skills. And if you're interested, join a special interest group. We've got a whole great group of people who are just really interested in these cross-cutting topics and passionate about it. So if you share in that as well, come and join us. And then lastly is planning for the annual scientific meeting. We will be announcing the dates and the location of that in the next couple of weeks. So have that in mind in your team meetings, in your project meetings over the next couple of months to decide who will be attending on your behalf. And lastly, this is probably a very British idiom, but don't be a stranger. So get to know us, get involved, send us emails. We love to hear from you. So it will be my pleasure to get to know all of you over the next few years of your project. So that was my whirlwind tour, but I will put some links in the chat, and please do get in touch, and I'd love to get to know you all better.
Thank you so much, Isabel. It was very helpful. I actually already have the question ready to pop up in the chat about the next annual scientific meeting, but I understand we need to wait, so we will do. In the meanwhile, and in order not to delay the presentations, I would pass the floor to Empower, or I see you are already ready, so.
Perfect. Thank you so much. And I'm Louise. I'm a PhD student at the Swiss TPH. And together with Clémence, who is a postdoc at the Luxembourg Institute of Health, we're happy to present the Empower project that we're part of. Like this. So a little bit about the background of our project. I mean, as you all know, NCDs is the leading cause of death in the world, and this particularly affects low and middle income countries, in particular also sub-Saharan Africa. So the Empower project is based in 2 countries, in Benin and Togo, where we see high prevalence, frequent multimorbidities, and a significant gap in screening, diagnosis, and treatment of NCDs. And we have based the Empower project on the chronic care model, which is an intervention that has previously been tested and happened in Southeast Asia. So the main objective of the Empower project is to reduce the treatment gap in rural areas of Togo and Benin, and doing that by strengthening the role that community health workers have there, and by using adapted digital health innovations and solutions. As part of Empower, we're targeting a broad range of NCDs, some of which being hypertension, dyslipidemia, diabetes, obesity, epilepsy, depression, anxiety disorder, as well as alcohol and tobacco use disorders. And our project is a 4-year project. We started in September last year, and it's going to last until August 29. Our project is split into 3 main phases. We'll dive into them in a bit. But first, it's the contextual analysis to really understand the context. Then we're using and testing the intervention, and later on, the monitoring and the evaluation of the intervention. So our consortium, we are 7 partners from 6 different countries. And you can find also more information on our website with our upcoming publications, information from our field work, and so on. So as I mentioned, our project is split into 3 different parts. And all of this is split again into 8 different work packages, each of which is led by a different part of the consortium. And now a little bit more about the contextual analysis, so the first part of the Empower project. So this part of the project really aims at understanding the context, so the ecosystem of individuals living with an NCD in Benin and Togo. And this is in order to later on be able to co-develop a community and digital health intervention that will help to strengthen awareness, screening, care, and follow-up of NCD. And the output, so the results of this part of the study will help us to directly use it in the second part of our study. To do that, we're using a mixed method study. So we're analyzing the demand side, meaning all caregivers and individuals that have NCDs, as well as the supply side, where we refer to health professionals as well as community health workers. And we, for both of these groups, we have done quantitative surveys as well as semi-structured interviews in order to really better understand the experiences, the perspectives on NCDs, the challenges, but also understand the acceptability of digital tools in the context of Benin and Togo. The data collection already took place in February and March of this year, and we've done that in the department of Weme in Benin and the Avi district of Togo. I will let Clémence continue.
I'm going to present phase B and C of the project. Next slide, please. So beside the primary objective of the evaluation, which is also the primary objective of the project, we have secondary objectives, which are to assess the intervention effectiveness in reducing adverse health events and improving quality of life. We will also evaluate the implementation criteria following the REAM framework, assess the cost effectiveness of the intervention, and also identify factors which are likely to influence future scalability of this intervention. These phase B and C are planned to last for 36 months. Next slide, please. So before starting the intervention on itself, we will have preparatory phase, which consists on training community healthcare workers and health professionals on the different activities they are going to conduct. And we are going to also conduct a baseline survey in order to estimate the baseline treatment gap. So for the intervention itself, it will start by awareness campaign in communities. Then people will be screened for NCDs, and individuals who will be positively screened for an NCD will be encouraged to go to healthcare facility for NCD diagnosis and management. So for all individuals with positive diagnosis of NCD will go through treatment, health education, psychological support. So throughout the intervention phase, there will be active follow-up and coordination of care between community healthcare workers and health professionals. Next slide, please. For the monitoring and throughout the intervention, we are going to perform monitoring to ensure that the program is being implemented as planned, and the evaluation will be done using a quasi-experimental approach with an intervention and control zone. Next slide, please. So what is different in our project is that we are not focusing on just one NCD, and we will combine traditional health education approach with digital components, and also through the ongoing data collection, we are going to allow close monitoring and evaluation of the implementation. Next slide, please. Thank you.
Thank you so much. It was quite perfect on time and very, very nicely presented. So I would now pass the floor to Anita from HIVE to follow up. This will be a lot of information for the discussion at Teams.
Thank you, everyone. I think you can now see my screen. So my name is Anita Bobazzi. I'm a senior project manager at the Institute of Entrepreneurship, and I will be presenting the HIVE project. We are the work package 6 leaders for the communication and dissemination. Just a few things regarding the project. We all know under which code this project was funded. The project has started in July 2025. It has a duration of 36 months. We have 4 different countries that we will have clinical trials at. We will be developing one mHealth application with a total of 15 partners from 10 different countries. And then this is just an overview of the HIVE. So HIVE's mission is to deliver an integrated NCD care and management for people living with HIV, while enhancing health equality and patient-centered care through evidence-based and cost-effective interventions. HIVE will also design a flexible implementation research framework to guide the introduction, feasibility, and sustainability and uptake of the integration HIV NCD's morbidity management in multiple settings, including both HICs and LMICs. So just a few things regarding the HIVE essential interventions. HIVE's core concept revolves around 3 essential interventions. The first one is the mHealth application, which will facilitate self-management and strengthen patient engagement and empowerment. The second one is the interpersonal counseling, IPC, to enable access to mental health support. And thirdly, we have the intervention of NCD care into existing HIV clinics to reduce the fragmented and uncoordinated HIV and NCDs care. This is just the work package breakdown. As we all know, we do have the horizontal one, which is the work package, the project management, as well as the dissemination, communication, and exploitation activities. Work package 2 is the implementation of the research framework and the elicitation of requirements. Work package 3 is the adaptation of HIVE's intervention. Work package 4 is the clinical studies, which have started but at the beginning. And then work package 5 is the implementation of the research, evaluation, and validation. The project has been divided into 3 different phases. Phase 1 is the planning phase, which is from month 1 until month 12. This phase will establish the foundation for the project through a comprehensive assessment of the local health needs and specific challenges, the engagement of the key stakeholders, and the development of the overall IRF. This phase will also include crafting the clinical trial protocol and conducting co-creation workshops to ensure interventions are contextually relevant and co-designed with a local input. So to have, let's say, to keep everything organized for all 4 clinical sites. Phase 2 is the adaptation phase, which has already started from month 5 and goes throughout month 16. This phase is dedicated to the adaptation of the mHealth application, the IPC, and the NCD's care protocols to the HIV context, including cultural, contextual, tailored to the specific needs of each target population based on the findings that we have from phase 1. And then phase 3, we do have the rollout phase, which is from month 16 to month 33, which is the clinical trial that will be carried out implementing and refined intervention across each country and target population. Lastly, we do have phase 4, which is the evaluation and the validation phase that goes throughout month 26 until month 36, which is the final phase, which is focused on the evaluation and validation of the IR outcomes. And the key metrics include adaptation, cost effectiveness, sustainability, and impact. This is just the draft of the logic model, which HIVE will follow and will be further defined and adapted to the local circumstances of each participating site with the help of the steering committee members and the stakeholders. So under work package 6, we have already finalized the steering committee, which is a network of experts that will be guiding the HIVE project throughout its duration and reviewing whatever is needed, as well as the guide the project's tasks and the content of the mHealth application. So a little bit more on the mHealth application. This is an already existing application that was developed by Columbia University in the United States, and HIVE will do an adaptation and extend the content and functionalities of this existing application without compromising its known effectiveness to serve its target population with specific medical and societal contexts. The features of this application include a knowledge hub, which is a space for users to get educated on health issues, the available treatments and options, as well as the lifestyle support where users receive guidelines and personalized recommendations on how to manage their specific conditions and complications, but also prevent health issues. The healthcare system navigator is also included in the app, which is a comprehensive guide of patients' rights concerning access to healthcare, a list of providers to assist with them in managing their MLTCs, and patient organization to support them in their journey. Furthermore, we have the Health Companion, which is a personal health diary for tracking symptoms, medications, schedules, and lifestyle habits. It could also provide tailored reminders for appointments, medical refills, health goals, alongside with insights based on the user data trends. In addition, we have the mental health, which is a platform connected to IPC facilitators, which they can request and schedule appointments, which can also be done through video conferencing sessions. And we do have the medication lexicon, which is a comprehensive medication dictionary offering detailed information on prescriptions over the content of the drugs, the supplements that patients might come across with. Users can search for drug interaction, side effects, and proper dosage without this app at any point being offering doctor advice, but rather than additionally to what their doctors are already giving them as instructions to follow. We also have the collaborative network platform, which will be developed on our website. You can find a link to register into this network. If any of you are interested in joining, we would be more than happy to have you. This will include regular communication and knowledge exchange, sharing of updates, materials, and good practices, discussion of the progress, challenges, and the solutions of the project, as well as support for collaboration and clustering activities. These are our partners. As we mentioned, we do have a total of 15 partners throughout 10 different countries. I wouldn't be a good communications and disseminations officer if I didn't ask you to connect with us on Facebook and LinkedIn, which we are active on. This is from my side. I wanted to thank you, everyone, and especially the organizers for today's invitation. It has been great meeting you again, even though we did have a few bilateral and in-person meetings already. So thank you, everyone.
Thank you so much, Anita. And thank you also for trying to keep up the time. So I think, Wouter, this is now your turn for MCare.
Thank you very much. Well, my name is Wouter Munneke. I'm a researcher at the Amsterdam UMC, and here I'm the coordinator of the MCare project, which is targeting implementation of an integrated care model for patients with multiple cardiometabolic and mental health conditions in sub-Saharan Africa. And specifically, our project right now targets on multiple regions in Ghana, Uganda, and Kenya. And I present this project on behalf of the MCare, which are 7 partners located in sub-Saharan Africa and Europe. Very briefly, well, why integrated care? Well, we believe that by integrating mental health and care for cardiometabolic diseases, that we better fit patient-centered care. And also studies demonstrate that addressing these comorbidities simultaneously can also improve recovery and also adherence to treatment, resulting in better patient outcomes. We also hypothesize that implementing it simultaneously can actually be more efficient. You can make use of joint training, supervision, and actually use less resources, which is very beneficial in low mid-income countries, and also making it more cost effectiveness for implementation, also sustainability, and also to contribute to reducing the stigma by normalizing mental health care within NCD services. So to break it down, we have several objectives, which are also separate work packages. So the first part of the project is to adapt, optimize, and co-create effective implementation strategies and tools for integrated care, which I hereby refer as the MCare model. Another work package thereafter is the implementation of the model in primary healthcare facilities in Ghana, Uganda, and Kenya, which will be evaluated throughout the whole project on implementation level outcomes. And we have a cluster randomized controlled trial to assess its effectiveness and cost effectiveness of the integrated care. And lastly, to make an impact is to develop an engagement strategy and policy recommendation to reach a sustainable and widespread use of integrated care, both in local, regional, national, and potentially international level. So the fundament of our project is actually on 2 guidelines, the WHO PEN and the MHGAP, which are clinical tools for implementing care in low mid-income countries in primary care. And we specifically target diabetes, hypertension, and dyslipidemia as cardiometabolic diseases, and common mental health conditions such as anxiety, depression, and substance use disorder. And within the development phase, which lasts almost a little bit longer than 2 years, we'll do evidence synthesis on lived experience of patients and to assess its effectiveness and implementation of previous studies. But mainly we'll use a strong stakeholder engagement and co-design with patients, communities, health workers, policymakers, and even beyond, to really develop a strong method that can be applicable. And when we talk about strategies, it is strategies such as training clinicians, creating consensus discussions with local stakeholders, providing digital technology, ensuring quality there, and also to improve the medication supply. Once this is developed, and also simultaneously, we will start implementing this within the different regions in the 3 countries. This lasts from 8 months, from month 8, almost up to 3 years, where we'll yet again use a strong co-creation and stakeholder engagement design, but also to recruit the facilities. And while developing, we will also implement it, and we do a pilot testing. So we'll use also implementation evaluations to further adapt the model that we're developing with within Work Package 2. And at the end, we'll after 2.5 years, we'll start a cluster randomized controlled trials in more than 230 primary healthcare facilities, in which we implement the MCare model in half of them. And we also aim to follow around 7,000 patients over a time span of 12 months. With this, we'll conduct a Type 3 hybrid effectiveness implementation trial, meaning that the main emphasis on the evaluation within our project is on implementation outcomes, primarily on the reach of patients, but also the other implementability of it. And secondary of it are the economic outcomes, as in the cost effectiveness, and also the clinical impact on patients. And by the end, so it's a 5-year project, and after 5 years, we aim to have written policy recommendations for implementing integrated care and its sustainability, and also to report on a roadmap towards large-scale implementation. Throughout the project, we'll have several or many communication and dissemination activities, and we'll also held 3 scientific stakeholder events and a closing symposium. And I also would like to share with you, but on the 28th of May, we also conduct a first webinar on integrated care and multiple long-term conditions. So with our project, there's several leaders. I won't go into in detail, but mainly the development of the implementation strategies and the recruitment and implementation are being done by our local stakeholders in Ghana, Uganda, and Kenya. And the evaluation and the coordination are conducted by partners in Europe. And yeah, therefore I want to thank you, and on behalf of the whole MCare consortium, and we look forward to finding synergies.
Thank you so much. So another very timely presentation. Thank you again for that. I would then, if you agree, pass the floor now to PEN Connect, Kirstine and Anna, I think.
Yeah, thank you very much. So it is my pleasure to present on behalf of the PEN Connect project, together with my co-lead Anna Mukumbi from the University of Eduardo Mondlane in Mozambique. PEN Connect stands for Connecting Primary and District Care for People with long-term conditions, long-term chronic conditions in Mozambique. So we are all very well aware about the rising prevalence of non-communicable diseases, and Mozambique in that regard is no exception. We do have a couple of figures for you. So hypertension affects around 25% of the population, diabetes mellitus in particular, then also impaired fasting glucose and mental health disorders are also on the rise. And as in many other countries around the world, NCD management is under-resourced, fragmented, and unfortunately poorly coordinated across healthcare levels. So what is expected is a surge in future NCD cases, and many of them affecting younger adults, and also increasing their risk of developing comorbid conditions later in life. And a lot of this is compounded by poverty, by socioeconomic factors, and the aforementioned weak health system. So this misalignment between initiatives that are already there, the current healthcare system, perpetuates fragmented care and also inconsistent referral pathways. And that's particularly the case between primary, secondary, tertiary, and also then back referral from tertiary to secondary and primary level care. So that what is very much observed in the country is a lack of continuity for patients with complex NCDs, undermining the efforts to provide effective care, to provide cohesive care, and that is directly impacting the quality of patient care. And PEN Connect tries to address that by bringing together two well-known packages, the PEN package, the package of essential non-communicable disease interventions, and then in addition, the so-called PEN Plus package. And that is then an initiative that is then also co-led and very much steered by my colleague Anna Mukumbi from Mozambique. And while WHO PEN is really directed at primary healthcare, PEN Plus is directed at district level healthcare. And while WHO PEN is then very much focusing on integration of hypertension and diabetes in Mozambique, PEN Plus is aimed at provision of better outpatient care for more severe and more complex chronic NCDs. And what's very interesting around PEN Plus is that it got endorsed by WHO AFO and has been adopted in 47 African countries in 2022. And considering also the strong interest in PEN Plus, this will also then allow for future scaling up opportunities. So our goals and objectives are really connecting primary and district care for people with hypertension, diabetes, and common mental health conditions in Mozambique, and thereby then also improving their health outcomes. So I already pointed out the importance of WHO PEN and PEN Plus as the major packages we are interested in. We'll work from patient to community, including informal traditional care to primary care, and then linking those to district care and specialized care. The co-created package we are then planning to evaluate in a type 2 hybrid design, a step wedge design, and we are going to work in a rural area called Namatanda, which is in the Beira province in Mozambique, in a more peri-urban, urbanized area, relatively close to Maputo in Makuruene. We'll address various implementation outcomes, looking at reach, effectiveness, adoption, implementation, maintenance, and of course, very important also cost, because being able then also to scale up would require this cost effectiveness assessment to also provide the figures needed to discuss with the Department of Health. We've set up the overall project based on the so-called APIS framework, looking at exploration, preparation, implementation, and sustainment, where we are currently in the phase to explore care gaps and context, both on patient, provider, and in addition system level, and will thereafter then move into preparing the prepare phase by co-creating the PEN Connect package with stakeholders prior to implementing, evaluating, and then by synthesizing the lessons, ideally then also to scale up for national and regional uptake. Community engagement is a very important part of the project, and I have a couple of photos to also showcase some recent activities based on the photo voice methodology to really then also engage community members and to learn about their experience of non-communicable chronic conditions. And the network, the consortium we have several institutions included next to the University of Eduardo Mondlane. The NCD Poverty Network plays an important role. We have colleagues from the London School of Hygiene and Tropical Medicine included, from the Ludwig Maximilians University and from the UMC Utrecht.
And some of the colleagues who've been able to attend then our initial consortium meeting, our inception meeting in Maputo, you see on this group picture. It's a large consortium. We look very much forward also to synergies with all the other projects. And I do also hope that many of our colleagues will be able then to collaborate with many of the other team members of the other project. Thank you very much. Yeah, and for information and to get a better understanding also about the project, please do not hesitate to visit our webpage or directly contact Anna Mukumbi or myself.
Thank you so much, Kerstin. Another very interesting presentation, all of them so far. So I will now pass the floor to Konstantinos from MULTIPULM, last but surely not least.
So thank you all. It's been a rich morning hearing from our sister projects. I'm Konstantinos Vagianos. I'm the project coordinator of MULTIPULM from Unisystems, and I will now walk you through what we are building and why. So imagine you are a patient with COPD, you also have diabetes and a heart condition, you see a pulmonologist, an endocrinologist, a cardiologist, and none of them talk to each other. Your medications make conflicts, nobody looks as you as a whole person. That is the daily reality for millions of people with multiple long-term conditions. And it's not a failure of the individual doctors, it's a system design problem. Care is structured around single diseases while patients face more than one disease. And here is where MULTIPULM comes to bridge the gap. So to keep that human reality at the center of our work, we created personas like Petar Petrovic. He's 64 years old, retired, lives in rural Serbia on a modest income. He's a former heavy smoker with COPD, heart disease, and diabetes, and he struggles to stay on top of his treatment. Petar isn't a real patient, but he represents thousands of real people. Every technical decision we make, we ask ourselves, does this actually help someone like Petar? You can see the key numbers on screen. What I want to emphasize is the logic behind them. 3 countries, Brazil, Serbia, and Turkey, because we deliberately chose very different health systems so that what works in our project has a real chance of working elsewhere too. 7 different digital tools because integrated care needs more than one app. It needs an ecosystem, and 2,750 patients because at this scale we can generate evidence that policymakers will actually trust. Before we build anything, we spent serious time understanding what's actually happening on the ground in each country, and the picture is sobering. So in Brazil, COPD is widely underdiagnosed, and primary care teams simply don't have multimorbidity protocols to follow. In Serbia, there are digital tools available, but they sit outside daily clinical workflows, and many patients lack the digital literacy to use them. In Turkey, the national digital infrastructure is actually quite strong, but care delivery still happens in silos, disease by disease. The one finding that cuts across all 3 countries, multimorbidity care pathways exist on paper in some places, but they are not operationalized anywhere. That's the gap, and that's what's exactly where our tools come in. So what did we build in response? You can see the full list on screen. I won't read through all 7, but let me highlight the thinking behind them. Some are patient-facing, serious games for breathing control, a binaural beats app for sleep, a lifestyle coaching platform. All these help patients like Petar manage their conditions day to day at home, and other are clinician-facing, AI-powered lung sounds analysis, voice biomarker screening for mental health, and then decision support system for risk stratification. And tying all together is our integrated care dashboard, the layer that connects patients, primary care teams, and specialists, so that for the first time, everyone sees the same patient picture. That's the piece that turns 7 separate tools into one ecosystem. None of this stays in the lab. We are running full-scale pilots across all countries. We have 2,000 patients in Brazil, 600 in Turkey, and 150 in Serbia. each lasting at least 18 months with follow-up. The goal is straightforward: prove that integrated digital care improves outcomes in the real world, not just in control environments. So we launched in August 2025. We're 8 months in, and I'm happy to say that we are on track. You can see the milestone timeline on screen. The first 2 milestones are already done. Governance is solid, our website is live, and our exploitation and dissemination strategies are active. But what I'm most proud of right now is the work that doesn't fit neatly into milestones. The stakeholder mapping using the pentahelix approach, the co-design sessions of patients' personas, and the regulatory groundwork that will make our pilots possible. That's the unglamorous work that determines whether pilots actually will succeed. So when we look ahead, our ambition goes well beyond publishing papers, although we do aim at least 20. We want to reach over 100,000 people through awareness, train more than 150 professionals, and most importantly, demonstrate a measurable improvement in patient quality of life, because at the end of the day, if Petar's life doesn't get better, none of the rest matters. So I will close with this. MULTIPULM is an open project. If any of what you've heard today resonates with your own work, we generally want to hear from you, whether that's clinical partnerships, digital health expertise, or policy collaboration. There is room at the table. Our details are on screen, and we are easily to find us on LinkedIn, YouTube, Twitter, X, Spotify, etc. Thank you very much, and I look forward to the discussion.
So it was a lot of food for thought, a lot of information. I'm not sure if there are any pressing questions. I think we can have a few minutes if anyone has some. And Ines, I don't know also if you have anything to launch.
Yeah, I mean, I was actually taking a look at the chat, and I was seeing here, well, I don't know, that Isabel, you shared something, right, as well here of some commonalities, and I was thinking that there have been so many interesting resources, and also the links for our websites and etc. And perhaps we can also have a follow-up with all of you who have been registered, so that we can share all of those things that have been shared here. So that would be nice, because we can see here that yeah, Isabel, you shared a lot of interesting things, I believe, for each one of the projects here.
Yeah, there's just some things that, not that I have a perfect knowledge of all 190 projects at GACD, but some past events and other projects that I noticed or that might link up nicely with the work that you're doing. And particularly, I would encourage you to take a look at our project library, because that has all 190 projects on there, and you'll find projects that are working in the same country as you, or on the same conditions, or with the same theories, models and frameworks. So if you want to get in touch with any of them, just let me know, but it gives you a sense of who else is doing what and where.
Thank you. It seems that we already have some homework to do and look at all of this, which is really very nice. I also saw some comments referring that multimorbidity, primary care, integrative care, CV, of course, resonating for all of our projects. So perhaps we can consider also exchanging some emails and seeing how we can discuss further these topics, put together our research. I saw that in most of the presentations, people are doing literature reviews or desk search, surveys, interviews, etc. So at the end, we will have maybe a lot of different outcomes, but some of them could be somehow put together. I don't know. Yeah, Wouter, please jump in.
Yeah, what I also noticed that it seems that every project has a very strong stakeholder engagement phase. And I think we can also find synergies in learning from each other's stakeholder engagement, and also mapping certain strategies to this implementation logic model. And I think we can learn a lot from each other. So I would also be very keen to search for synergies on during this phase already.
Yeah, one of the things we were discussing was what we could do next, because also so that Isabel knows, in our bilateral meetings and then by email, we all discussed that we would like to eventually propose a workshop for the next annual scientific meeting of the GACD with the project together. So maybe this can be considered. Of course, this was just an initial idea from one of the colleagues and we didn't discuss what, but maybe based on today's interactions, we can either discuss a bit more about the topics that I was now mentioning, or even as Wouter was mentioning, maybe we can discuss a bit the barriers and enablers for engagement, for stakeholder engagement in different countries. I don't know. I think we have a big batch of possibilities. But please, Isabel, let us know.
Yeah, just a quick one to say that obviously there's great projects here funded under the EC, but the multiple conditions research program at GACD is bigger. There are 9 projects and potentially a few more, depending on what happens with the US NIH as well. So it's beyond just the EC projects here, and I'd encourage you, if we can, is to bring everyone into that conversation, and we can certainly help facilitate that, just because already they're funded under the same call text that you were, so there's going to be connections and commonalities.
Yeah, sounds very good and even more ambitious. So of course that that's nice. I see Anita and Kirsten also with hands raised. Please go ahead.
Yeah, thank you again to everyone for today. I wanted to maybe suggest something. I don't know if it would be something more simple. If everyone's okay, we could also do maybe a Teams channel. So for more direct communication, and then also upload content there. We can also share files and then have a lot of more direct, rather than maybe getting lost in a lot of emails. I don't know if this would be something easier for everyone.
Thank you, Anita. I think so, and certainly we already put forward in the initial discussions that we would like to have a shared platform. So I guess we should do this in the after this webinar, which makes a lot of sense. I know that we still need to collect some feedback from some projects saying that you agree to share your emails in this, but these are practicalities. We'll go through it. Kirsten?
Yeah, thank you. Thank you all very much, and also for the presentations and all the contributions. Very interesting to learn about all the different projects. And I would want to second the idea to have an opportunity at the next AGM of the GACD to present about our projects, possibly then also including the other funded projects under the multi-mobility umbrella. And what may be interesting is, because many of us are looking forward to a 4 or 5 year funded project, that we then also look at a topic that's particularly of interest and for all of us for the first year work that we are all doing, so that we can also then throughout our own project phases and then through attending then also the AGMs over the years, that we then can also pick up a very important topic for all of us, a bit aligned and also to the stages our projects are in.
Thank you so much. So I think you already have some positive answers, Isabel. People seem to be all interested. Marina, you also raised your hand.
Yes, thank you. Very nice ideas. What I heard, there is a big family of the GACD projects, all that you can find there, some synergies, but you can consider some more light actions targeted in thematic areas. I have this experience because I follow up the clustering of obesity projects, for example, and they have some thematic areas like digital, like research aspects. So they meet not only at the coordinator level, but at operational level with working within working groups and discuss challenges and opportunities, and they plan some activities, some webinar around these thematic areas that they are quite successful and open to the public as well. I mean, public, mostly the scientific community. So we know that already managing a project like this, it's already tough, and you have to find light and efficient activities that could increase your impact, your networking activities, and even future work on implementation research, which is going up not only in the context of GACD, but in general.
Yeah, thank you very much. Indeed, this is this is the approach that we have in other projects, for example, for Mission Cancer, to have this division, let's say, by areas. So perhaps if the other projects agree, once we solve all of the sharing emails, etc. issues, we can put a document forward and try to have like 3 working groups between us so that we can kind of divide work between different areas. I think it's a very nice suggestion. If you all agree, we can see where does it get us. So I think we are getting close to the end. I will again just give a note. Please don't forget to follow each other's projects. And I noticed that MULTIPULM has a community of practice, but also, Anita, you presented a platform where the others can register, and maybe there's something else in your other projects. So maybe we can also share these and try to follow up on each other, because that will be surely a good source of knowledge and networking. I cannot thank you enough, also on behalf of Inês, for all of the quick reactions you had to the organization of this webinar. Thank you so much for everything. And again, thank you for the support of Marina and Isabel. I do hope that this is the beginning of a lot of more work that we'll do in the following months and years. And I don't know, Inês, maybe you want to formally close it?
Yeah, sure, Karina. Well, we are actually, we only have 1 minute to go. So I think that beyond what you said, that thanking everyone, we will follow up with all of you, because there have been so many interesting ideas here, like having a Teams channel or something, or any other kind of platform where we can share this work, and maybe perhaps create working groups in different areas that can be emerging also throughout the different phases of the projects. One of these topics were actually stakeholder engagement, and to possibly have a workshop in the GACD annual scientific meetings. So, well, we will be happy to follow up with all of you, read these ideas and many others that I believe we can have in the future. Once we exchange even more. So thank you so much. I think that's it. And hope to see you soon.